Hi, I'm Nurse Marcia. Today we're tackling hot OB-GYNE topics for the NGN NCLEX RN, packed with challenging scenarios to sharpen your clinical judgment. From postpartum emergencies to gynecological crises, let's dive in, build your confidence, and get you exam ready. Ready to ace this? Let's go.
Case study. A 35-year-old client, G2P1, is admitted at 37 weeks gestation with complaints of severe headache, upper right quadrant pain, and visual disturbances. Vital signs reveal a blood pressure of 172/114 mmHg, heart rate of 98 BPM, and respiratory rate of 20 BPM. Laboratory results include platelets, 85,000, AST, 120, UL, ALT, 98, UL, proteinuria, 4+. Question 1. Select the findings that indicate an urgent need for intervention: severe headache, visual disturbances, platelets, 85,000, Me3, proteinuria, 4+, BP 1/72/114. Answer: all except visual disturbances. Rationale: severe headache, thrombocytopenia, platelets less than 100,000 per mm3, significant proteinuria, 4+, and critically high BP of 1/72/114 mmHg are hallmark indicators of severe preeclampsia with progression to HELLP syndrome, hemolysis, elevated liver enzymes, low platelets. These findings signal end organ damage and an urgent need for medical intervention to prevent complications like eclampsia, seizures, liver rupture, or disseminated intravascular coagulation, DIC. While visual disturbances are a concerning symptom, they are not as urgent compared to the other findings and do not independently indicate imminent danger. 2. What is the priority intervention? What is the nurse's first action? A. Notify the provider immediately. B. Start magnesium sulfate infusion as ordered. C. Initiate continuous fetal monitoring. D. Administer hydralazine for BP control. Answer: C. Initiate continuous fetal monitoring. Rationale: in severe preeclampsia, the nurse's primary focus should be assessing fetal well-being to determine whether the fetus is tolerating the compromised utero-placental perfusion. Continuous fetal monitoring evaluates for signs of fetal distress, such as late decelerations or minimal variability, which may necessitate emergency delivery. Magnesium sulfate is critical for seizure prevention, but is not the first action. Hydralazine or other antihypertensives are used to control BP, but are initiated after fetal status is determined. Notifying the provider is important, but the nurse must gather all critical information, including fetal monitoring data, to report a comprehensive assessment. Immediate fetal monitoring allows for prioritizing maternal and fetal interventions effectively. 3. Which finding indicates that magnesium sulfate therapy is effective? A. BP decreases to 140/90 mmHg. B. DTRs decrease from 4+ to 2+. C. Client reports relief of headache. D. Urine output increases to 30 mmol/hr. Answer: B. DTRs decrease from 4+ to 2+. Rationale: magnesium sulfate reduces neuromuscular excitability, preventing seizures. A reduction in DTRs from hyperreflexia, 4+, to normal reflexes, 2+, confirms its effectiveness. BP control is achieved through antihypertensives, not magnesium. Improved urine output reflects kidney function, but is not specific to magnesium therapy. 4. The client develops a tonic-clonic seizure despite receiving magnesium sulfate. What are the nurse's priority actions? A. Administer calcium gluconate. B. Call for assistance immediately. C. Protect the airway. D. Administer a second bolus of magnesium sulfate. E. Turn the client to the left side. Answer: C. B. E. Rationale. During a seizure, the nurse's priority is to ensure safety by preventing aspiration, turning the client to the left side, and maintaining a clear airway. Administering calcium gluconate is not indicated unless magnesium toxicity is present. Additional magnesium may be considered after seizure cessation, but airway protection takes precedence. Case Study 2. A 29-year-old client, G1P1, delivers vaginally after a prolonged labor. 1 hour postpartum, she reports feeling lightheaded and is noted to have heavy vaginal bleeding saturating 2 pads in 15 minutes. Vital signs include BP 90 over 60 mmHg, HR 128 BPM, and RR 24 BPM. 5. Select the findings that confirm postpartum hemorrhage. A. Heavy vaginal bleeding saturating 2 pads start 15 minutes. B. BP 90 over 60 mmHg. C. HR 128 BPM. D. Prolonged labor. E. RR 24 BPM. Answer: A, B, C. Rationale: PPH is diagnosed when blood loss exceeds 500 ml after vaginal delivery. Hypotension and tachycardia indicate hemodynamic instability due to excessive blood loss. Prolonged labor may contribute to PPH but is not diagnostic on its own. 6. Which actions should the nurse take first? A. Massage the fundus. B. Encourage oral fluids. C. Administer oxytocin IV as ordered. D. Notify the provider. E. Start a second IV line with normal saline. Answer: A, C, D, E. Rationale: fundal massage promotes uterine contraction, reducing atony, the most common cause of PPH. IV fluids help maintain perfusion. Oxytocin enhances uterine tone, and the provider must be notified to evaluate further management. Oral fluids are inadequate for severe hemorrhage. 7. Which finding indicates successful management of PPH? A. HR decreases to 100 BPM. BP stabilizes at 110 over 70 mmHg. B. Client reports no lightheadedness or dizziness. C. Fundus is firm and bleeding is minimal. D. Hemoglobin stabilizes at 10 g per dl after transfusion. Answer: C. Fundus is firm and bleeding is minimal. Rationale: a firm uterus indicates effective contraction, reducing bleeding. Vital signs and symptoms, options A and B, improve later, while hemoglobin stabilization reflects long-term management. Case Study 3. A 30-year-old client, G2P1, is admitted at 32 weeks gestation with complaints of lower abdominal cramping and increased vaginal discharge. A sterile speculum exam reveals the cervix is 2 cm dilated and 70% effaced. Fetal heart rate is 140 BPM with moderate variability. The client is contracting every 8 to 10 minutes. 8. Select findings that suggest preterm labor. A. Abdominal cramping. B. Cervix 2 cm dilated. C. Vaginal discharge. D. FHR 140 BPM with moderate variability. E. Contractions every 8 to 10 minutes. Answer: A, B, E. Rationale: preterm labor is diagnosed when cervical changes, dilation or effacement, accompany regular contractions before 37 weeks. Increased vaginal discharge may indicate infection or cervical changes, but is nonspecific. FHR of 140 BPM with moderate variability is reassuring and unrelated to labor status. 9. What is the nurse's first action? A. Administer betamethasone as ordered. B. Start tocolytic therapy, example nifedipine. C. Obtain a fetal fibronectin test. D. Position the client in left lateral position. Answer: C. Obtain a fetal fibronectin test. Rationale: fetal fibronectin testing helps confirm preterm labor. Positive results suggest delivery within 7 to 10 days, guiding further interventions. Betamethasone and tocolytics are critical, but initiated after confirming preterm labor. Positioning is supportive but not diagnostic. Case Study 4. Scenario: a 27-year-old client, G1P0, delivered vaginally 1 hour ago. The nurse notes a boggy uterus and heavy bleeding saturating 2 pads in 20 minutes. Vitals: BP 88 over 60 mmHg, HR 132 BPM, RR 26 BPM. 10. Select findings indicative of postpartum hemorrhage. A. RR 26 BPM. B. Heavy bleeding saturating 2 pads per 20 minutes. C. BP 88 over 60 mmHg. D. HR 132 BPM. E. Boggy uterus. Answer: B, C, D. Rationale: a boggy uterus and excessive bleeding are hallmark signs of uterine atony, the most common cause of PPH. Hypotension and tachycardia confirm hemodynamic instability. 11. What is the nurse's first action? A. Administer oxytocin. B. Massage the fundus firmly. C. Notify the provider. D. Start a second IV line. Answer: B. Massage the fundus firmly. Rationale: fundal massage is the first-line treatment for uterine atony, promoting uterine contraction and reducing bleeding. Oxytocin and IV fluids support management but follow initial fundal massage. Provider notification occurs once immediate interventions are underway. 12. Which finding indicates effective management of postpartum hemorrhage? A. Hemoglobin increases by 1 gdl after transfusion. B. BP stabilizes at 170 mmHg. C. Firm uterus, minimal vaginal bleeding. D. Client reports feeling less dizzy. Answer: C. Firm uterus, minimal vaginal bleeding. Rationale: a firm uterus indicates successful uterine contraction, reducing bleeding. Stabilized vitals and hemoglobin levels confirm secondary management, but are not immediate indicators. 13. A client at 38 weeks gestation reports reduced fetal movement for 12 hours. What is the nurse's first action? A. Perform a non-stress test, NST. B. Auscultate the fetal heart rate with a Doppler. C. Instruct the client to drink orange juice and rest. D. Notify the provider immediately. Answer: B. Auscultate the fetal heart rate with a Doppler. Rationale: a Doppler assessment ensures the fetus is viable before proceeding with additional diagnostic tests or notifying the provider. An NST or fetal kick count assessment may follow based on initial findings. 14. Which findings indicate true labor? Select all that apply. A. Regular contractions increasing in intensity. B. Cervical dilation and effacement. C. Contractions relieved by rest. D. Fetal station at +1. E. Bloody show. Answer: A. Regular contractions increasing in intensity. B. Cervical dilation and effacement. E. Bloody show. Rationale: true labor is marked by cervical changes, regular contractions, and the presence of bloody show. Fetal station indicates progression, but is not specific to true labor. Contractions that resolve with rest suggest false labor. 15. Reorder the steps for managing shoulder dystocia. A. Perform McRoberts maneuver. B. Apply suprapubic pressure. C. Call for additional assistance. D. Document the event. Answer: C. Call for additional assistance. A. Perform McRoberts maneuver. B. Apply suprapubic pressure. D. Document the event. Rationale: calling for help ensures adequate personnel. McRoberts maneuver is the first-line intervention, followed by suprapubic pressure to dislodge the shoulder. Documentation occurs after the emergency is resolved. 16. Select the findings that confirm the diagnosis of gestational diabetes mellitus. A. Fasting glucose of 102 mdl. B. 3-hour glucose tolerance test abnormal. C. Postprandial glucose 140 mdl. D. Client concerns about the baby's health. Answer: A. Fasting glucose of 102 mg/dL. B. 3-hour glucose tolerance test abnormal. C. Postprandial glucose 140 mg/dL. Rationale: gestational diabetes is diagnosed when fasting glucose levels exceed 95 mg/dL and postprandial levels remain above 140 mg/dL after a 3-hour glucose tolerance test. Client concerns are valid but do not confirm the diagnosis. 17. What is the nurse's priority teaching point to address the client's concerns? A. Insulin therapy may be necessary to control blood glucose. B. Frequent ultrasounds will ensure fetal growth is monitored. C. Strict glucose control reduces the risk of complications. D. The baby is at risk for developing type 2 diabetes later in life. Answer: C. Strict glucose control reduces the risk of complications. Rationale: educating the client about the importance of glycemic control empowers her to actively manage her condition, reducing the risk of fetal macrosomia, hypoglycemia, and other complications. Insulin therapy and fetal monitoring are essential but secondary to achieving glucose control. 18. Select the findings that indicate fetal distress. A. Recurrent late decelerations. B. Minimal variability. C. Supine positioning. D. Epidural in place. Answer: A. Recurrent late decelerations. B. Minimal variability. Rationale: late decelerations indicate uteroplacental insufficiency, while minimal variability reflects fetal hypoxia or CNS depression. Supine positioning contributes to poor perfusion but is not a direct sign of distress. Epidurals are unrelated. 19. What is the nurse's first action? A. Reposition the client to the left lateral position. B. Administer oxygen at 10 LE-min via non-rebreather mask. C. Notify the provider of the findings. D. Decrease the oxytocin infusion rate. Answer: A. Reposition the client to the left lateral position. Rationale: repositioning improves uteroplacental perfusion by relieving pressure on the inferior vena cava. Oxygen and decreased oxytocin are appropriate, but follow maternal repositioning. The provider is notified if distress persists. 20. A client at 34 weeks gestation reports painless vaginal bleeding. What is the nurse's first action? A. Assess fetal heart tones with a Doppler. B. Perform a sterile vaginal exam. C. Administer RhoGAM if the client is Rh negative. D. Initiate an ultrasound to evaluate placental location. Answer: D. Initiate an ultrasound to evaluate placental location. Rationale: painless vaginal bleeding suggests placenta previa. A vaginal exam is contraindicated as it may worsen bleeding. Ultrasound is the safest method to confirm placental location before proceeding with further management.
Thank you for joining me. Again, this is Nurse Marcia on this journey through advanced OB-GYNE scenarios for the NGN NCLEX RN. If you found this helpful and want more tips, challenging questions, and nursing insights, don't forget to like, subscribe, and share my channel. Let's keep growing, learning, and preparing for success together. See you in the next session. Stay confident. You've got this.